Okay, thank you so much, Esther, and thank you for the invitation to be here, and thank you all for joining us here in beautiful Colorado. I'm glad we have some nice weather for you today. I know it was rainy last night. I was actually at Red Rocks, freezing and soaking wet last night, so I hope you're all drier and happier than I was. But thank you for having both of us. Dr. Bayram and I specialize in a type of dementia called Lewy body dementia, and we are always very happy to find those intersections and overlapping joint efforts to make sure we are combining our knowledge and resources, making sure that we make more progress together than in our separate silos of the different conditions. And so what we're going to present to you today is where those intersections are in terms of the clinical features, how we as cognitive and movement disorder neurologists think about these things. When somebody comes into our clinic and we're trying to figure out what's going on, how we think through it, and to bring you onto our team of expertise so that you know what we're looking for, help us find those things to come to the right diagnoses together as a team. Here are our disclosures in terms of just grant funding and support for our center at the University of Colorado. Here's an outline of what we'll cover. I'm going to start with some of the terminology and definitions of movement disorder phenomenology, so a fun word to say, in terms of what types of abnormal movements, moving too much, not enough. Then we're going to talk about how the intersections of cognitive, behavioral, language, movement features can present in different ways in these different conditions. And as we'll learn, we might be wrong in a lot of the ways we're classifying these syndromes. As we're getting better tests and biomarkers and biological definitions of these diseases, how we're currently classifying things may change. And then lastly, Dr. Bayram will review some of our research and educational overlap. Okay, so movement definitions. When we are talking about movement disorders, as opposed to motor disorders, and we're going to have some more talks later this afternoon focusing more on neuromuscular or motor manifestations, but for movement disorders, in terms of the basal ganglia, these deep gray matter structures inside the brain that are interacting with our cortex, the outer crust of the brain, and talking back and forth to the rest of the brain, to our spinal cord and our arms and our legs. But movement disorders are coming, in most cases, from dysfunction of these deep basal nuclei. They act as a kind of filter as well as a thermostat for setting where the body should be moving. Not too much, not too little. We categorize movement disorders into two main groups: hypokinetic, not moving enough, not enough movement; hyperkinetic, moving too much. Now, often people don't follow that distinction or that split, and there can be a little bit of too much, a little bit of too little movement. But in terms of how the basal ganglia are controlling that set point of keeping the body in the right Goldilocks zone of movement and not allowing too much or overly suppressing normal movements. For hypokinetic, not enough movements, the biggest category here is Parkinsonism. Ism looks like Parkinson's, but as we'll see, that Parkinson's is not the only kind or form of Parkinsonism. The core features of Parkinsonism being bradykinesia, slowed movement. There is normal strength. The gray matter, the neurons in the motor cortex, the frontal lobe, that connect all the way down through to our spinal cord, to our nerves and our muscles, they're all fine. They're just being overly suppressed. So when you test the person's strength, it's full, they're strong. It takes a while to get to full strength, but it's possible, it's there. And what we do when we're examining people, we have them go through all these little dance moves and tap their toes and walk around. And what we're looking for is the overall natural speed of their movement. How easy, fluid, automatic is it? What is the amplitude of that movement? Does it stay big, or does it start trailing off and getting small? Does it look disrupted or interrupted, like it's not smoothly happening? Akinesia is the far end of the spectrum of bradykinesia, where it's so slow, it's not moving anymore. Freezing of gait is a complete block where the brain is saying, please move, and the body's not listening. Very common that people have freezing of gait when they are changing the patterns of the floor, or if they're going through a tight doorway or hallway, that there's a little bit more of a block there and the body gets stuck. And then rigidity, which is stiffness, too much tone. So we all have resting tone in our muscles where the muscles are kind of ready. They're not too tight, they're not too loose, they're ready to move. In rigidity, the muscles at their resting state are too tight. And that can cause some degree of cramping or pain or lack of range of motion. Separate from Parkinsonism in terms of those hypokinetic movements, apraxia, which is difficulty with learned motor programs. So things that we might not have naturally embedded as programs in our brain, but we've learned over time. And the way that we do this as neurologists, we'll say, show me how you brush your teeth, right? And ask people to kind of mime it and show us how they're doing it. Or show us how you would put a key into a lock and turn it for me. And so again, it's not a strength issue, it's the programming of the deeper basal ganglia turning those programs on in a very specific way. As we talk about Parkinsonism, probably one of the most common questions I get asked is, well, isn't Parkinson's disease and Parkinsonism the same thing? Aren't they interchangeable? And just like we talk about dementia as an umbrella or a category with subtypes underneath, that Parkinsonism is a category where it just means slowness, stiffness, and/or shakiness, but the underlying cause of that slowness, stiffness, and shakiness is split up into two separate categories. Primary Parkinsonism, usually neurodegenerative diseases, where those brain cells responsible for those motor programs, turning on and off certain types of learned movements, releasing the movements to happen easily, naturally, and automatically, those brain cells are primarily damaged and lost. As opposed to secondary Parkinsonisms, where the brain cells are there, they may have been damaged in other ways, strokes being the most common example, and even if somebody never had a major clinical stroke, they've had enough hardening of the arteries in their brain over long periods of time that cause scarring in those same types of connections. But that the brain cells responsible for these connections are still there. Those primary Parkinsonian conditions, Parkinson's disease is the most common cause of Parkinsonism, but it's not the only one. And many times in our clinic, all we can say at the first visit is that I see Parkinsonism on the examination, or I'm hearing about it in people's histories, telling me I feel slower, stiffer, I see that they're shaky, they're falling, but that I can't say it's Parkinson's disease as the cause of their Parkinsonism unless I have looked for these other things, other primary Parkinsonian conditions, as well as these secondary ones. Dementia with Lewy bodies being that close cousin of Parkinson's disease, the only difference between Parkinson's disease and dementia with Lewy bodies being what came first. In Parkinson's, it's trouble moving the body. In dementia with Lewy bodies, it's the cognitive impairment. There is no other difference between the two. 80% of people living with Parkinson's will eventually get dementia. It just comes later. Whereas in dementia with Lewy bodies, that's the primary problem. That's why they're seeing the doctor. But the hallucinations, the acting out of dreams, the fluctuations, they're the same in both conditions. Now, as I alluded to in terms of biological definitions of disease, and as we're getting better with biomarkers of understanding what's in somebody's brain without waiting for them to pass away to look for it, that these two might really be more on a spectrum together than completely separate entities. Multiple system atrophy being closer related to Parkinson's and dementia with Lewy bodies in that all three have alpha-synuclein deposits in the nervous system. And then, as this audience is much better aware than usually my Parkinson's audiences, progressive supranuclear palsy and cortical basal degeneration. The secondary Parkinsonisms being the vascular, either a clear clinical stroke, afterwards the person was Parkinsonian, or smaller, gradual blood vessel changes over many years that made the person more Parkinsonian. What I do typically see more in the vascular Parkinsonism is that it affects the legs more than it does the hands when I'm watching them on examination. There's nothing perfect in an exam that would separate them, and really it's more things like brain imaging, seeing how somebody does over time, and it's a lot of the same symptomatic treatments. Medications are going to be another very common cause of secondary Parkinsonism, anything that blocks the chemical dopamine. So the dopamine-producing cells are still there, their action is being blocked. Usually antipsychotic medications used for things like schizophrenia or bipolar disorder, or anti-nausea, anti-vomiting medicines often also work by blocking dopamine. And even if the person's not on those medicines anymore, but they were on them in the past, especially if they were suddenly stopped, you can have this tardive Parkinsonism where there's these abnormal movements even once the medicine is no longer on board. Metabolic disorders and toxic exposures can also induce Parkinsonism. So hypokinetic Parkinsonism and apraxias, hyperkinetic, moving too much. Tremor, and this can get confusing, including for our residents, our fellows, our trainees. Well, wait, tremor is in Parkinson's, but you just told me Parkinson's is hypokinetic. It crosses boundaries, it does not follow the rules. The tremor is an extra movement, but it is an aspect of Parkinsonism. But a tremor is a rhythmic oscillation around a joint. It can be at rest, which is typically what we see in Parkinson's disease. It can be with posture or action, which we usually see a little bit more in things like essential tremor or medication-induced tremors. Stereotypies are extra purposeless movements that may seem a little purposeful, but they're repetitive, either vocalizations or motor movements, things like clapping or grunting or hand flapping, which is common in people with autism spectrum disorders, but these are also hyperkinetic movements. Chorea and athetosis, which are extra dance-like, writhing or jerking movements, most commonly seen in people with Huntington's disease. Dystonia, which are extra muscle contractions that can cause pain and fixed postures, most commonly something called cervical dystonia or torticollis, where the neck muscles get very tight and can pull the head in different directions, as outlined in that picture at the bottom. And then myoclonus is another type of hyperkinetic movement disorder, and these are very quick, lightning-like muscle jerks, and these can happen in many different brain conditions. So we have some common terminology now of how we categorize what we're seeing in front of us in terms of moving too much or not enough. This flow chart comes directly from my first-year medical student lecture on neurodegenerative diseases. I've made it nice and pretty and colorful, But I pull this up on the screen for the first-year medical students, and I can see the panic set in very quickly. And I say, please don't memorize this. You don't need to know all of this right now. This is a behavioral neurology fellowship on one slide. This is what our fellows are training to distinguish and to think through these different branch points in terms of what are the prominent accompanying features to that progressive cognitive decline, and then where does the person fit best. It is not as pretty and simple as this in real life, as many people in this room are aware of, but this is how our brain thinks through this unique person, this unique brain sitting in the room with me. Where do they fit on this algorithm? Now, this version is by what the person's experiencing and what I'm seeing as the examiner. We then have to combine it with what the underlying etiology, what is changing in this brain, because the clinical syndrome and the underlying neuropathology don't always match up as perfectly as outlined here. But the first step in anybody's medical education in terms of this neurology is at least knowing the common associations. So the three big neurodegenerative dementias, Alzheimer's, amyloid proteins building up in the brain, the memory predominant form of Alzheimer's being the most prominent and common, but the visual variant, posterior cortical atrophy, the logopenic primary progressive aphasia is in Alzheimer's disease in many cases, and then a dysexecutive or frontal form of Alzheimer's, which is the most commonly confused with the early stages of behavioral variant FTD. The Lewy body dementias, as we already chatted about, with alpha-synuclein proteins in the brain, Parkinson's disease dementia, dementia with Lewy bodies, and then our frontotemporal dementias, most commonly tau or TDP43 proteinopathies. I'm not going to go into as much detail on the motor neuron pieces of it, because that's not movement. Motor and movement, as we'll see, different, and I'll leave that to my colleagues specializing in ALS. But in terms of the FTD Parkinsonisms and the overlap with genetic features that we'll dive more into. So when I overlay the first rainbow slide with the last slide, this is what we get. Doesn't follow the rules. We got purple scattered, the blues at least kind of stick in a nice little place in there, but the greens are also scattered all over. And then this doesn't even bring in some of the other newer proteinopathies that we've been discovering lately, and that we might instead have mixed pathologies that maybe in the future our jobs will be looking at a personalized profile of biomarkers and the relative amounts and interplay rather than trying to fit somebody neatly into one of these boxes. This is what my life is, all these red arrows in the clinic, because I present it this way to our trainees to at least not scare them off, right? We need to recruit more of us, so there's not enough of us to go around. So I don't show them the red arrows until I've already got them and they're stuck in my fellowship training. And I usually start breaking the fellow's brain around September, so they start in July, and then they don't know enough until September, until they realize the red arrows, and then they go have an existential crisis and second guess all their career decisions. Hopefully we get better lab tests and other biomarkers that match into, of course, most importantly, the unique human being sitting in the room with us. But how can we better categorize things for people to get them to the right types of treatments, trials, understanding their future and what we're looking for them over time, which is the most common question we get in the clinic. So, in frontotemporal dementia, the movement manifestations can do anything. Too much movement, not enough movement, a mix of both. Sometimes it starts as not enough movement, then becomes too much movement. It can be the first symptom of FTD, as we'll see, especially in some of the genetic forms, you can see movement disorders first. And that my pretty rainbow and color classifications does not hold up in the real world. How does FTD affect those basal ganglia? So in the primary Parkinsonian disorders, the basal ganglia are what is changing pathologically. In frontotemporal dementia, it is mostly the frontal and temporal lobes. There is also some primary basal ganglia changes, but it's more a downstream change because as we're learning, the brain is not just real estate of this neighborhood does this, that neighborhood does that. It's the intersections, connections, those places where networks are forming that really defines what a certain part of the brain does. And that everything we've learned about neuroanatomy for hundreds of years has been that part of the brain breaks, what does the person look like? So that part of the brain must do that. But what we're seeing now with more advanced neuroimaging and other testing is that that part of the brain that was damaged connects with that and that and that, and knocking out one node of that network made it seem like that part was responsible, but it was really instead more of an important circuit and network that was changing. So as the frontal lobes are changing in people with FTD, the crosstalk, the cross wires and communication between the frontal lobe and the deep basal ganglia are changing too. And that's where either the release of the basal ganglia and allowing too much movement, or the over-suppression of the basal ganglia and leading to not enough movement. So in terms of hypokinetic movements, in the non-Parkinsonism forms of FTD, the other kinds, what do we see? Mostly Parkinsonism, as reflected in this large study a few years ago, 191 people with FTD, with behavioral variant, non-fluent, semantic, and motor neuron disease represented. We saw Parkinsonism in many of these groups, with the most obvious Parkinsonism in the non-fluent PPAs. The FTD motor neuron disease overlap also had a lot of Parkinsonism, the least in the semantic variant. Looking to see why, was it because there was more blood vessel problems in the people with Parkinsonism? Was it actually secondary vascular Parkinsonism? And it was not. If you had Parkinsonism with your FTD, you were also more likely to experience hallucinations and delusions, more other neuropsychiatric and behavioral symptoms, and more dependence in your daily activities. Now, this smaller piece of the FTD Parkinsonism, separate from the other more defined areas where Parkinsonism is just a small piece, but that Parkinsonism is a major aspect of these people's FTD. We're not going to spend too much time on PSP or CBD here because there was a great talk last year, and it's online if you want to watch it from last year's conference. But more specifically, this FTD 17, which is FTD Parkinsonism associated with chromosome 17. Back in the 90s, we started to see that there were a few families with an autosomal dominant pattern of inheritance. It seemed to be related to chromosome 17, and there was a mix of FTD and Parkinsonism in these families. That's where MAPT was found in 1998, then progranulin, and then C9 in 2011. In terms of which types of abnormal movements do we see in each of these genetic forms of FTD Parkinsonism, we see more of a progressive supranuclear palsy picture or a behavioral variant in the MAPT. We see some presentations that look more like dementia with Lewy bodies in terms of hallucinations and fluctuations in progranulin, but also cortical basal or non-fluent presentations. And then C9 can, interestingly, look like Huntington's disease in a lot of cases. But what we teach our medical students is if you see a mix of different types of neurological presentations in your patient, some Parkinsonism, some chorea, some behavioral, some cognitive, you need to think about C9, especially if you get a family history of a lot of other mixed abnormal movement, cognitive, and behavioral syndromes, even if those other family members had other diagnoses like Alzheimer's or Parkinson's, you need to look for C9. In terms of those likelihoods of Parkinsonism overall, about 80% when we combine all three of these genetic mutations, and that up to 27% of people started with the movement disorder. And that if somebody was coming into a movement disorders clinic where they focus on Parkinson's disease and the other things like dystonias and tics and chorea and stereotypies that we talked about, they might not be thinking about FTD. And that reasons why Dr. Bayram and I are trying to train more crosstalk and cross-training, I'm both a cognitive and movement disorder specialist, is so that people aren't slipping through the cracks like this in the no man's land between subspecialties. Hyperkinesia is moving too much. In terms of what we can see in FTD, it's all of them. Probably most commonly and most noticeably in people living with FTD being the stereotypies. So these are involuntary, purposeless, repetitive, even somewhat compulsive. They can stop it, but their brain is just kind of telling them to do it. It can in some ways be self-soothing, but it's not a type of thing that they are actively doing or controlling. And it's part of the diagnostic criteria for BVFTD is a movement phenomenology, but yet our movement disorder specialists are often not thinking about this. In terms of seeing new onset stereotypies, and whether it's a cognitive or behavioral or movement disorders presentation, if you see an adult with stereotypies and they did not have them in childhood or adolescence, there's not a history of autism spectrum disorder, you need to be thinking about FTD. And then the chorea, those extra body movements, dancing, writhing, jerking movements that we most commonly associate with Huntington's disease, also called Huntington's chorea, that this is also commonly seen in some types of frontotemporal dementia, especially in the fused-in sarcoma mutations, the FUS mutations, where their brains can look exactly like Huntington's disease MRIs. And you test for Huntington's disease, and the gene is negative. And then again, unless the movement disorder specialist is thinking outside the box, more into the cognitive field, to think about testing for fused-in sarcoma genes. So there's a lot of overlap between movement disorders and frontotemporal dementia. We need to do a better job sharing our knowledge and expertise, and that it can be too much, not enough, or a mix of abnormal movements. Up to 30% of people diagnosed with FTD, it started as a movement disorder. And sometimes we're not putting two and two together for people and thinking that was something else. And that really the genetics of FTD with MAPT, progranulin, C9, and fused-in sarcoma is a really important area that we need to be focusing on jointly to understand how these manifestations are coming out. With that, I'll turn it over to Dr. Bayram in terms of those ways we are sharing our expertise and our work together.
All right.
Oh, thank you.
Okay, when I'm not doing my bodyguard duties for Dr. Holden, I work on research. So everything Dr. Holden told you about actually came from research, and it was because many, many people with these diseases decided to participate in research, and their legacy lives on in all the efforts we continue to do. So if you were in Dr. Forsberg's breakout session this morning, you may have heard a little bit more details about observational studies. I'm not going to go over this classification too much, but I just want to point out, we always care about getting rid of the diseases. If we see a disease, we want to cure it, we want to prevent it, but we can't really start there for the most part. We, at first, got to start understanding diseases. What is happening? Why is it happening? And then we think about, okay, what can we do to stop it and get rid of it? And even if you have a cure for a disease, your job is still not done. You still have to make sure everyone has access to the cure, everyone knows about the cure. So the work of research never rests. And observational studies are really, really important for us as much as the clinical trials, the interventions that we're trying to do. Unfortunately, research takes time and a lot of persistence. We deal with a lot of failure in research. It's not like you find a miracle molecule and you test it out in animals, it works, awesome. You move on to the humans, it works, awesome. Let's approve it, let's make it available for everyone, voila, the disease is cured. That's not the case for the most part. A lot of the drugs, approaches for treatment that we see help in non-human models, they don't really work as well for humans. And at times, we don't even know if they're safe to use in humans, so we can't just, throw it onto the humans right away. We got to check for the safety and if the drug is effective or any other intervention. So we first start out with smaller groups, and then over time, we make the groups larger and larger if we're surely seeing that the drugs interventions are safe, they are showing an effect. We're going to test it out in larger and larger groups of people, but a lot of the times we see that those effects aren't actually as we expected. We see a lot of failure. So it takes time. We test out a lot of drugs because of that. That is why at any time there are so many different clinical trials happening, because we're really, really working hard to get to that effective drug. But it just takes a lot of work, unfortunately. And these are 5 points that clinical trials right now are really, really trying to be better at, so we can bring better clinical trials to you. But because of all these different points as well, it takes so much time to build a clinical trial. That is why, you sometimes see it on the news like, hey, this new thing worked amazingly in mice models, and you may bring it up to your doctor like, hey, I want that drug. I saw that it works in mice models. It's probably going to take like 7, 8, maybe 10 years for it to actually hit the human study phases. Things really, really take time, because in medicine, our first principle always is do not cause harm. We want to make sure whatever we do brings you no harm as we're trying to help you out with the diseases. And that is why when we're thinking about the target to go after in a clinical trial, we got to make sure that it has to do with the cause of the disease. It has a direct link to what's happening, to the changes happening in your body. And if we're talking about tauopathies, if we're talking about FTD, there are so many different mechanisms that are going wrong. And we know this because of observational studies. And actually, a lot of the things we know about the cause of frontotemporal dementia comes from autopsy studies. So people who have donated their brains after they passed away, families who have donated their loved ones' brains, they actually helped us get to this knowledge and actually help, start creating clinical trials that can target the causes. Once you have a good target, you got to think about, okay, what is the drug going to be? Is it engaging with the target as you want and leaving all the other targets alone because you don't want to fix one thing and ruin everything else? And, it may look good in blood. Is it reaching the brain even? Not everything in the blood reaches the brain. Is there some other way you have to deliver the drug? And, you want to make sure that you include the right people in the trial. If you're going after a specific gene, you may want to include people that have problems with that gene in your trial. So you want to make sure that you're going after the right people. You're not wasting anyone's time. You're not wasting the participants' time either. You want to make sure the drug you have is engaging well with the target without causing any problems. And then you got to track, all right, is the drug really helping? And for that, you rely on many different things. You do want to get the person's perspective. You want to see if it's helping with their symptoms, if it's helping with their daily life, but you also need to see changes happening in their body as well. And we are, slowly getting better and better with the biomarkers that give us that objective measure to understand how things are changing in FTD. And we're getting more and more clinical trials using that too. That is why sometimes if you participate in a clinical trial, we want to poke you, steal some of your blood, steal some of your cerebrospinal fluid. It's not because we just love it. It's because we're going to check for these biomarkers and see if the drug we're giving to you is actually helping you out and making any changes. So figuring all these things out, building a trial, it takes a lot of time. It's not as easy as you would think. And right now, we're past the stage of those classical trials where you have one group that gets the treatment, drug, whatever you're after, and another group that doesn't get anything, they just get the placebo. We're past that. There are still trials like that because we know it's an effective model, but we also know, especially in rarer diseases like FTD, we have to be a bit more logical about how we recruit people into trials. So sometimes we can test out different trials, different drugs in one trial. We can have one placebo group for so many different drugs and different study groups, or maybe we can test out one drug in different types of diseases that have to do with the similar cause. And you're going to see more and more of these trials happening right now because we're adapting the FTD trials to be these updated, better suited trials for the community. And we do see increase in research too. People are interested and invested in frontotemporal dementias. And even though we may not have disease-modifying treatments yet, there is a lot of studies at work that is happening that is trying to find disease-modifying treatments. And beyond the disease-modifying treatments, we're still ongoing with observational studies because we know we got to understand this disease more. If we haven't been able to cure it yet, it's because we got to learn a bit more about the disease. And we're really hustling to get everyone's experience represented in these studies. Because let me tell you, if you have FTD, you're probably going to experience a whole different disease than someone else you meet that has FTD. And that is why we really, really commit to trying to get people involved with the observational studies to get every experience represented properly so we can understand the disease better and develop better options to move on to the clinical trials. And I just did a quick look into, okay, what's happening in the US for these studies. And you can see all FTD is really, really ruling US, and it's giving a lot of amazing research output. And we have already seen its effect in clinical trials. It has triggered a lot of pharmaceutical companies to see that, hey, this group of patients want to do research. They're interested in research. They can be recruited for research. They're worth investing in. And we're seeing a rise in clinical trials just because of that. I'm going to fly through a little bit. And there's also symptomatic treatment trials still going as well. You know, if you get a cut, you may put a Band-Aid on it. Band-Aid's not going to fix it, but it may, make your life a bit better. So that is what the symptomatic trials are offering too. It's not like, oh, it's not changing my disease, so I shouldn't go for it. What's the point of it anyways? No, we want to make sure you maintain a good quality of life regardless of not being able to change the disease directly either. So these are still worthwhile, and these are still worth your effort to be involved in. Until we reach the point where we have available disease-modifying treatments, and we're in this field because we have a lot of hope that we're going to reach there. You know, we're not committing our lives to a lost cause here. We're really hustling for you because we know this is a worthwhile journey. We know we're going to get a good outcome and celebrate with the community very soon. We have a lot of high hopes. There are so many options available for symptoms. Not everything works amazingly, but there are still options. One size does not fit all. You all may be in need or in search of different things based on your symptoms and how you want a treatment to impact your daily life. And all the things we know was thanks to all the participants so far. So get involved with research. If you've done research before, maybe you had a bad experience, it doesn't mean you're always going to have a bad experience. You still have to, you know, give back and participate in research. So I just want you to think about, why should I participate in research? No, don't think about that. I want you to think about, why shouldn't I participate in research? There's no reason not to participate. You know, it's not just about yourself, you're gonna help others, but also about yourself. You're gonna get first dibs on a lot of treatments because you're gonna be the one that is using them the first, and when the trials are positive, they're gonna move into the open label before they hit the market. And if you're in that study, you're gonna be able to keep using that treatment. So, you know, you're getting the advantage right off the bat. And also, as researchers, clinicians, we're very, very anal about participants in research studies. We want to ensure your safety like no tomorrow. So we're going to give you so much extra care and attention because we want to make sure we're not causing you any harm in research. So you're going to get a lot of extra attention, even though it's not necessarily a clinical visit. You know, research, you can't really give clinical feedback. But if we catch something, oh, we're going to be on it like insane. So you're going to be in such safe hands. So I'm going to end with this lovely lyric from a cool band that you may have heard about. They're pretty new, up and coming, but I love them, and I really, really like this song they have, Hey You. You know, just remember, FTD, you experienced it alone, but we're going to cure this together, and we're in this fight all together. So remember, together we stand, divided we fall. Thank you.